हैं कि आपको यूके टाइप के केसेस आपको दिखाएं, जो जो एक्सपेक्टेड रिपोर्टिंग है, यूके स्टाइल ऑफ रिपोर्टिंग है, वो हम आपको बताएं। क्योंकि हम सारे आपकी ही उससे गुजर कर सारे इस जगह तक पहुंचे हैं, तो हमें पता होता है कि कौन सी इमेजिंग मोडेलिटीज़ या कौन सी इमेजिंग वैरायटीज़ जो है ना, या कौन सी टाइप ऑफ डिजीज़ेज पाकिस्तान में कॉमन नहीं है, वो आप वहाँ पर नहीं देखेंगे। और वो आपसे वाइवास में एक्सपेक्ट की जाती हैं और पूछी जा सकती हैं। तो मैं थोड़ा सा, मैंने कुछ स्लाइड्स तैयार की हैं। तो मैं चाहूँगा मैं पहले वो डिस्कस कर लूँ, उसके बाद हम कैंडिडेट्स की तरफ से जाएंगे। और मेरी ये एक्सपेक्टेशन होगी कि जो बातें हम डिस्कस करें वो कैंडिडेट्स जो है ना अपने वाइवे के अंदर उसको रिप्रोड्यूस करें। अ, मैं अपना स्लाइड शेयर करता हूँ। कैंडिडेट नंबर वन, इज माई स्लाइड विजिबल?
Yes, sir, it is.
थैंक यू, थैंक यू। सो हम आज उन चीज़ों के बारे में पढ़ेंगे जो कि एक सीटी चेस्ट के अंदर कार्डियक मेनली वेस्कुलर रिलेटेड एब्नॉर्मेलिटीज होती हैं, जो कि ओवरलुक हो सकती हैं। और आपने अपनी अप्रोच, सिस्टेमिक अप्रोच इस तरह बनानी है कि आप से वो एब्नॉर्मेलिटीज ओवरलुक ना हो, इग्नोर ना हो, और आप उसको डिटेक्ट कर सकें। जो एक और फर्क होता है FRCR टू बी एग्जाम में और FCPS एग्जाम में, कि आपको स्टेशन नहीं पता होता। एक सीटी लगता है, वो आपसे कहते हैं सीटी खोलें, वो आपको हिस्ट्री बताता है, लेकिन आपको स्टेशन का नहीं पता होता, जो कि मेरे ख्याल में सही काम है। तो आपको ये नहीं पता होता कि ये जो एब्नॉर्मेलिटी होगी वो वेस्कुलर होगी, कार्डियक होगी, लंग होगी, या बोनी होगी, कुछ भी हो सकती है। वो आपकी अप्रोच को चेक करते हैं। तो कुछ क्लूज मैं आपको बताऊंगा कि जिसको आप फॉलो करें, कुछ सिस्टेमिक अप्रोच बताएं, तो ताकि आपकी जो कार्डियोवेस्कुलर जो एब्नॉर्मेलिटीज हैं वो आपसे मिस ना हो। तो एक रेडियोलॉजी असिस्टेंट का आर्टिकल है, उसके अंदर दो अप्रोचेस बताई हुई हैं। एक है गो विद द फ्लो मेथड, दूसरा है फाइव कॉर्नर अप्रोच। तो हम आज इन दोनों को थोड़ा सा डिस्कस करेंगे। गो विद द फ्लो अप्रोच बहुत आसान अप्रोच है। उसके अंदर आपको बताया हुआ है कि आपको फ्लो का अंदाजा होना चाहिए, ठीक है, कि SVC से फ्लो आता है, हेड एंड नेक से, और IVC से एब्डोमेन और पेल्विस वगैरह से सारा फ्लो आता है, और वो ड्रेन करता है राइट एट्रियम में। ठीक है, जो वीनस फ्लो है आपका सारा का सारा, वो ड्रेन करता है राइट एट्रियम के अंदर। ठीक है, और उसके बाद राइट एट्रियम से जाएगा वो राइट वेंट्रिकल में, राइट वेंट्रिकल के बाद उसके बाद वो जाएगा पल्मोनरी आर्टरीज वगैरह से, फिर ऑक्सीजनेशन होगी उसका। तो पल्मोनरी वेन्स के वो फ्लो आएगा लेफ्ट एट्रियम में, लेफ्ट एट्रियम से फिर लेफ्ट वेंट्रिकल, लेफ्ट वेंट्रिकल से फिर एओर्टा के थ्रू सिस्टेमिक सर्कुलेशन में होल बॉडी में डिस्ट्रीब्यूट होगा। ये नॉर्मल फ्लो होती है। ठीक है, और इस फ्लो की जहां पर डिसरप्शन होगी वो आपने डिटेक्ट करनी है। तो ये बहुत इंपॉर्टेंट है कि आपको सारी फ्लो का अंदाजा होना चाहिए। इसमें मैं एक चीज पर थोड़ा सा फोकस करूं, जो कि मेरे एग्जाम में भी आई थी, जैसे SVC की एनोमलीज और उनकी जो है ना वेस्कुलर वेरिएशंस जो है ना, एनाटॉमिकल वेरिएशंस, वो आती रहती हैं कि डबल SVC है, या फिर जो है ना IVC की एजाइगस कंटिन्यूएशन है। तो ये एनॉमलीज, ये वेस्कुलर एबनॉर्मेलिटीज, ये आपको पता होनी चाहिए। अगर आपको नॉर्मल फ्लो का पता है और नॉर्मल फ्लो को आप सीटी के अंदर डिटेक्ट कर सकते हैं, तो ये वेस्कुलर एनॉमलीज आपको इसको डिफरेंशिएट करने में आसानी होगी। तो मोस्ट इंपॉर्टेंट चीज़ ये है कि आपको नॉर्मल फ्लो का पता हो। ठीक है, उससे जो चीज़ भी एबरेंट है वो एनॉमली है। तो जैसे हम कहते हैं पैथोलॉजी इज एबनॉर्मल एनाटमी, तो अगर आपको नॉर्मल एनाटमी का अच्छा अंदाजा है, आप उसको पिक कर सकते हैं। तो जो चीज़ भी एबनॉर्मल है वो एबनॉर्मल है। दूसरी चीज़, ये आपसे FRCR 2B एग्जाम में एक्सपेक्ट की जाती है, वो आपसे जो सिंड्रोम्स वगैरह भी होते हैं ना, उनके नाम की एक्सपेक्टेशन नहीं होती। अगर आपने उसको अच्छी तरीके से डिफाइन कर दी है और आपने उसको रेडियोलॉजिकली मेंशन कर दिया कि इसमें ये रेडियोलॉजिकल एबनॉर्मेलिटी है, ये रेडियोलॉजिकल एबनॉर्मेलिटी है, अगर आपको उस सिंड्रोम का नाम पता भी नहीं है तो इट्स ओके। वो आपसे एक्सपेक्ट ये करते हैं कि आपको नॉर्मल एनाटॉमी पता हो, और नॉर्मल एनाटॉमी में जो वेरिएशन है वो आपको पता होनी चाहिए। ठीक है। ठीक है। दूसरी जो अप्रोच है, वो जो बहुत इंपॉर्टेंट है, वो है 5 कॉर्नर अप्रोच। ठीक है। हम जो सीटी देखते हैं उसमें हम हर चीज़ देखते हैं, लेकिन कुछ चीज़ें ऐसी होती हैं जो बहुत इंपॉर्टेंट होती हैं, जो आपने देखना बहुत इंपॉर्टेंट है। तो कोई किसी भी वेस्कुलर एनॉमली को डिटेक्ट करने के लिए ये 5 कॉर्नर्स या 5 प्लेसेस ऐसे हैं जहां पर आपने लाजमन देखना है कि अगर कोई एबनॉर्मेलिटी हो तो यहाँ पर आपको नजर आ जाएगी। ठीक है। तो हम इन इसको बारी बारी हम देखेंगे। केस के अंदर हम देखेंगे कि इसको आप कैसे अप्रोच कर सकते हैं। ठीक है। तो ये 5 कॉर्नर अप्रोच है। जो इसमें से पहला जो कॉर्नर है वो है एसवीसी का। एसवीसी के अंदर जब यहाँ पर आप देखें तो राइट अपर पल्मोनरी वेन का जो और एसवीसी का जो पॉइंट है, इंटरसेक्शन पॉइंट है, वो इम्पोर्टेंट है। ठीक है। तो हमने डिस्कस किया कि जो हमने इसको डिस्कस किया कि जो एसवीसी है और आईवीसी है वो राइट एट्रियम के अंदर ड्रेन करती हैं, और जबकि जो पल्मोनरी वेन्स हैं वो लेफ्ट एट्रियम के अंदर ड्रेन करती हैं। ठीक है। तो ये अगर ये राइट अपर पल्मोनरी वेन है, अगर ये एसवीसी के अंदर ड्रेन कर रही है और ये राइट एट्रियम में जा रही है बनस्बत लेफ्ट एट्रियम के, तो इसका मतलब है कि ये शंट है। ठीक है। तो ये एबनॉर्मल कम्युनिकेशन है। तो इस चीज को मेंशन करना, इसको इस प्लेस पर देखना बहुत इंपॉर्टेंट है, क्योंकि यूजली ये इस जगह पर इसके अंदर ड्रेन करती है एट द लेवल ऑफ पल्मोनरी आर्टरीज। ठीक है। तो ये एक कॉर्नर है, एक प्लेस है जिसको देखना बहुत इंपॉर्टेंट है। ठीक है। दूसरा है अलोंग द लैटरल एस्पेक्ट ऑफ द एओटिक आर्च है, जो एओटिक आर्च का लेवल है और जैसे ही वो खत्म होने वाली है उसका लेवल, और अलोंग द लैटरल एस्पेक्ट कभी कभी डबल आईवीसी डबल एसवीसी वगैरह होती है या लेफ्ट साइड एसवीसी होती है, वो आपको यहाँ पर नजर आएगी। तो इस पॉइंट को देखना बहुत इंपॉर्टेंट है, आपके नज़र में ये पॉइंट होना चाहिए। ठीक है। अ, उसके साथ ही हम ये भी डिस्कस करते हैं एओर्टो पल्मोनरी जंक्शन जो है ना वो बहुत इंपॉर्टेंट है। एओर्टो पल्मोनरी जंक्शन जो है ना वो बहुत ज़्यादा इंपॉर्टेंट है। और वो एरिया जो है ना खासकर डिस्टल टू द लेफ्ट सबक्लेवियन आर्टरी, आप देख सकते हैं यहाँ पर कोई कोऑक्टेशन ऑफ एओर्टा आपको नज़र आ सकती है। ठीक है। एओर्टो पल्मोनरी जंक्शन में हमने पिछले सेशन अगर आप थे उसमें हमने पढ़ा था कि प्लीज़ प्रेजेंटेशन के ऊपर एनोटेशन ना करें। राहत राहत शाह जो है ना मुख्तलिफ एनोटेशंस कर रहे हैं, मैं इसको 1 मिनट ब्लॉक कर लेता हूँ। अच्छा। तो ये वाला जंक्शन जो है ना बहुत ज़्यादा इंपॉर्टेंट है। हमने पिछले अगर आपको याद हो, हम पिछले सेशन में भी हमने इसको देखा था कि जो रिकरेंट लेरिंजियल नर्व्स है, जो राइट साइड रिकरेंट लेरिंजियल नर्व है वो जस्ट जो राइट सबक्लेवियन आर्टरी के नीचे से कर्ल होती हुई वापस जाती है। तो राइट सबक्लेवियन आर्टरी के नीचे जो भी राइट अपर पैराट्रेकियल लिम्फेडेनोपैथी है वो उसको इसकी पैरालिसिस काज कर सकती है, और जो कि लेफ्ट रिकरेंट लेरिंजियल नर्व वो जाती है डिस्टल टू द आर्च, जो लेफ्ट सर्कुलर आर्टरी के नीचे से वो जाती है, आर्च के बीनीथ से वो ट्रेवल करती हुई ऊपर जाती है। तो कोई भी जो एबनॉर्मेलिटी है वो एओर्टो पल्मोनरी जंक्शन में हो, वो लेफ्ट रिकरेंट लेरिंजियल नर्व्स को का पैरालिसिस काज कर सकती है। ठीक है। तो ये इंपॉर्टेंट है ये जंक्शन। फिर उसके बाद तीसरा जो लेवल आप कह सकते हैं वो एओर्टिक रूट के लेवल पर है, जहां पर कोरोनरी का ओरिजिन होता है। ये अक्सर हम उसमें डिस्कस कर चुके हैं कि इस लेवल पर जो है ना मेलिग्नेंट ओरिजिन ऑफ कोरोनरी आर्टरीज हो सकती है। तो ये लेवल देखना भी बहुत इंपॉर्टेंट है। चौथा लेवल है बिल्कुल डिस्टल, जो डिसेंडिंग थोरेसिक एओर्टा के लेवल पर अगर यहाँ पर कोई आपको बड़ी सी वेन दिखे जो कि नीचे होती हुई जा रही है, तो वो जैसे शिमिटर सिंड्रोम होता है या फिर कोई भी सिस्टेमिक ड्रेनेज वगैरह होती है, वो आपको यहाँ पर नज़र आ सकती है पल्मोनरी वेन्स की। ठीक है। तो ये 5 लेवल्स हैं जो कि बहुत इंपॉर्टेंट हैं, जो कि वेस्कुलर एनॉमलीज की डिटेक्शन में आपकी हेल्प कर सकते हैं। इसको हम 5 कॉर्नर अप्रोच कहते हैं। ठीक है। ये हमने डिस्कस कर लिए। रेडियोलॉजी सिस्टम में डिटेल से दी हुई है, तो आप वहाँ पर जाकर काफ़ी डिटेल से इसको पढ़ सकते हैं। केसेस भी हैं तो वो भी दे सकते हैं। मैं रिकमेंड करूँगा कि आप ये चीज़ वहाँ से पढ़ लें। ठीक है। और ये कॉमन कार्डियोवास्कुलर केसेस है जो उन्होंने दिए हुए हैं, जिसका आप स्क्रीनशॉट ले सकते हैं और वहाँ पर जाकर इसको पढ़ सकते हैं। कुछ नॉर्मल डायमीटर्स हैं जो कि आपको थोड़े बहुत पता होना चाहिए, आपसे पूछे जा सकते हैं। ये भी मैंने वहाँ से लिए हैं, तो आप देख सकते हैं। एओर्टिक एंडोरिज्म की डिफरेंट गाइडलाइंस हैं। जो यूके की गाइडलाइंस हैं वो ये हैं कि अगर एओर्टा का डायमीटर मोर देन 5 सेंटीमीटर हो तो हम उसके अंदर और उसको कोई कंजेनिटल वेस्कुलर कार्डियोवेस्कुलर कोई डिजीज ना हो, तो हम उसको कार्डियक कार्डियक सर्ज या कार्डियोवेस्कुलर सर्जिकल रेफरल करते हैं, ताकि उसका जो है ना एंडोरिज्म का सर्जिकल ट्रीटमेंट हो सके। ठीक है। अ, इसमें बेनिफिट क्या है, 5 सेंटीमीटर हमने क्यों चुना है, 6 सेंटीमीटर क्यों नहीं है? तो ये जो लेवल है वो एक तो चेंज होता रहता है। ठीक है। दूसरी बात ये है कि 5 सेंटीमीटर हमने इसलिए चुना है कि क्योंकि ये जो सर्जिकल प्रोसीजर है जिसमें एओर्टा की रिप्लेसमेंट हम करते हैं, उसके अंदर जो जिसकी मोटिलिटी है, पोस्ट ऑपरेटिव मोटिलिटी है, इट इज लेस देन द एओर्टिक चांसेस ऑफ एओर्टिक रप्चर, उसकी वजह से जो मोटिलिटी हो सके, इसकी बेस पर ये लेवल चुना जाता है। ठीक है। तो अकॉर्डिंग टू द डेटा, तो जो लेवल चुना गया है एओर्टिक एंडोरिज्म का सर्जिकल रेफरल के लिए वो 5 सेंटीमीटर है। ठीक है। इन द एब्सेंस ऑफ एनी कंजेनिटल या फिर मार्फन सिंड्रोम या कंजेनिटल कार्डियोवास्कुलर डिजीज। अगर पेशेंट में मार्फन सिंड्रोम का अगर उसने आपको पेशेंट बता दिया है, तो उसके लिए जो लेवल है जो कि कार्डियोवास्कुलर सर्जरी को रेफरल का लेवल है वो 4.5 सेंटीमीटर है, वो 5 सेंटीमीटर नहीं है। ठीक है। तो ये एओर्टिक गाइडलाइंस के मुताबिक ये रिकमेंडेशन है जो कि आपको पता होनी चाहिए। अच्छा। इसके बाद ये कुछ पिछले सेशन में भी आई थिंक मुझसे क्वेश्चन हुआ था राइट एट्रियम और लेफ्ट वेंट्रिकल के डायमीटर जो हवाले से। कार्डियक एमआर में जो हम करते हैं या फिर जो मेन हमारा कार्डियक सीटी होता है, उसमें यूजली हम वॉल्यूमेट्रिक एनालिसिस करते हैं। उसमें हम ये एपी डायमीटर्स वगैरह नहीं लेते, हम उसमें वॉल्यूम्स में बात करते हैं कि राइट वेंट्रिकल का एंड डायस्टोलिक वॉल्यूम कितना है, राइट वेंट्रिकल का एंड सिस्टोलिक वॉल्यूम कितना है। उसकी अपनी वैल्यूज होती हैं जो कि इंडेक्स्ड होती हैं टू द पेशेंट बॉडी हाइट और बीएमआई के हवाले से इंडेक्स्ड होती हैं। ठीक है। जबकि इसके अलावा ये क्रूड मेथड्स हैं, इसके ज़रिए से भी आप जो है ना कार्डियक डायमीटर्स ले सकते हैं। ठीक है। वो ज़्यादा स्टैंडर्ड है वॉल्यूमेट्रिक असेसमेंट, लेकिन ये कुछ क्रूड नंबर्स हैं जो आपको आपकी डेली लाइफ में, डेली प्रैक्टिस में आपकी हेल्प कर सकते हैं अगर कोई सीधी चेस्ट आप पढ़ रहे हैं। ठीक है। और ये ट्रांसवर्स मेयरमेंट पर है, मोस्टली लेफ्ट एट्रियम का उन्होंने एपी मेयरमेंट पर दिया हुआ है जो कि 5 सेंटीमीटर है। अच्छा, ये कुछ वैल्यूज हो गई। और ये एक्यूट एओर्टिक सिंड्रोम जो कि एक एओर्टिक इमरजेंसीज हैं जो कि बहुत कॉमन है यहाँ पर, हमारे सेंटर में कॉमन है क्योंकि एक कार्डियोवास्कुलर सेंटर है। तो आपके एग्जाम में आ सकती हैं, जैसे इंट्राम्यूरल हेमाटोमा हो गया, एओर्टिक डायसेक्शन हो गया और पेनिट्रेटिंग एथेरोस्क्लेरोटिक अल्सर हो गया। तो इसके डिफरेंशिएटिंग पॉइंट्स आप सब लोगों को आने चाहिए, ये इंपॉर्टेंट है। ठीक है। तो ये चीज़ें थी, ये हमने देख ली। जो इम्पोर्टेंट चीज़ आज डिस्कस हुई है वो ये है कि आपको नॉर्मल फ्लो का पता होना चाहिए कि नॉर्मल ब्लड फ्लो कैसा है। ठीक है। और दूसरी चीज़ है आपको ये पता होना चाहिए कौन सी चीज़ आपने कहाँ पर देखनी है और कौन से 5 ऐसे पॉइंट्स हैं, 5 ऐसे कॉर्नर्स हैं जहाँ पर वेस्कुलर एनॉमलीज हो सकती हैं और आपने उनको वहाँ पर डिटेक्ट करना है। ठीक है। तो हम केसेस से स्टार्ट करते हैं। कैंडिडेट नंबर 1, मैं अपनी स्क्रीन शेयर करता हूं दोबारा।
So may I start?
जी बिल्कुल।
Okay, so 40 years old male presented with multiple trauma from a severe beating, now unresponsive, and there is suspicion of hypertension. pH of hyper. Okay.
एक मिनट, एक मिनट। कैंडी नंबर वन, मैं आपको
Yes, sir.
केस दिखाता हूँ, फिर आप स्टार्ट करें, ठीक है?
ठीक है, sir.
मैं केस की तरफ जाता हूँ। ठीक है, ये एक स्कैनोग्राम है आपके लिए, आप प्लीज इसको डिस्क्राइब करें, उसके बाद केस को ओपन।
Okay, so I'm provided with a scanogram of a mature skeleton in which I can see the skull, the frontal projection of the neck. Then I can appreciate the chest and the abdomen. It's actually showing almost the entire upper portion of the body. And in these images, I would like to zoom in my normal routine practice to see if there are any fractures. I can identify any definite fractures as the patient had a history of beating. And other than that, I can appreciate that there's slight mediastinal widening noted at the level of the aortic knuckle. It could be projectional as the patient is slightly rotated. And however, I would like to confirm it on the CCT chest. Other than that, I cannot
Okay,
appreciate any
so
definite.
कैंडी नंबर वन, what would be the protocol of the CECT test?
Ideally, it should be done without contrast as well to see if there's any hematoma to rule it out because there would be hyperdensity only visualized on the pre-contrast images. Then I would like to go for the arterial phase and then the delayed phase to see if there's any contrast pooling or blush of contrast is noted. And
You will do it in three phases.
arterial,
Non-contrast.
photovenous, and delayed. Four phases.
You will do
Pre-contrast,
it.
arterial.
Okay. You're planning. So what will be the effect of dose on the patient? So you will give such high dose to the patient. Is it justified to give?
Um, the pre-contrast is a must because we have to rule out the hematoma. I think then arterial should also be done to rule out the acute pathology at that level. I think the delayed is also necessary if there's any contrast. I think arterial or pre-contrast would be if to rule to reduce the dose.
Okay. So we have done a non-contrast. Can you please review that?
Okay. I'm provided with the axial CT chest without contrast, in which I can appreciate. I cannot appreciate any definite pathology in the bilateral lung fields. I would like to scroll once from top to bottom. The descending thoracic aorta is normal as I'm going up. I can see that there is some hyperdensity that is noted along the anterior mediastinum, and the aortic arch also appears to be, there is hyperdensity noted along the anterior aspect of the arch of aorta. And however, I cannot appreciate any hypodensity along the left pleura or within the left pleural cavity. It is not making any apical cap sign. And as I'm going down, there is evidence of aortic hematoma. There's hematoma within the wall of the aorta, and I would like to further confirm these findings on the post-contrast images to see if there's any definite contrast extravasation.
Okay. Here's a post-contrast images.
Okay, so as okay, so now I can scroll. Now I would like to scroll from top to bottom as I'm going down. I can appreciate that the contrast is normally opacifying the left, the right brachiocephalic, the left common carotid and the left subclavian artery, and it is originating normally from the arch of aorta. Now, at the level of the arch of aorta, I can see that there is a hypodensity that is traversing the aortic arch, and there is also thickening noted along the aortic wall, and I cannot see any definite active contrast. Okay, over here I can. There is, I think, there is some tracking of the contrast along the descending aorta within the surrounding soft tissue, and the contrast is specifying normally into the pulmonary trunk, and the aortic root is also normal. And now, as I'm going down, the descending aorta is also normally contrast specified, and now I'm evaluating the heart. I think both the ventricles are normal contrast specified. So, and I cannot see any other cross pathology. So, summing up all the findings, I think there is an likely aortic transaction that is noted at the level of the aortic arch, with active contrast extravasation that is seen in the surrounding soft tissue, and with surrounding hematoma formation. And this is an emergency. I would urgently pick up the phone and convey my findings to the vascular surgeon on call to manage this patient.
Okay, okay, good. Um, if I would describe it, I would describe as a tear
Okay.
in the aorta, and usually these tears are due to shearing injury.
Okay.
That shearing injury rather than active trauma at that site. So due to that shearing injury, there is a tear, and this is the site of isthmus, which is below the left subclavian artery, which is the most common site for this kind of an injury. And also usually the sites which are more prone to these shearing injuries are at the junction of mobile and non-mobile aorta. So, and usually close to the branching points, these are the points which are usually prone to these kind of injuries. So,
Okay.
initially you said you will do non-contrast, which is really good. In all the acute aortic syndrome, we will do a non-contrast scan first. And then you said arterial phase, venous, and delayed phase, which will be too much
Okay.
radiation dose for the patient. Ideally, arterial phase is enough. If there is an arterial
Okay.
leak, you will be able to see that. If you are more suspicious, you can say that I would like to supervise the scan myself.
Okay.
And if needed, I will do a venous or a delayed phase image. But we don't do both. We will do either one.
Okay. I just
So
wanted to ask a question that, like in our setup, in the trauma series, we do the scan of patient from head to toe, because if there is any suspicion of abdominal trauma, so then can we add the portovenous and the delayed, or just like in chest, it's just the non-contrast in the arterial?
yeah, for the chest, but it will depend what is the indication. Like for a trauma protocol, we do like kind of a portal venous phase of the abdomen. We do
Okay.
that.
Okay.
But for the acute aortic syndromes, what you will
Okay.
advise is that one more thing is also important. You need to tell that to do the thoracic aorta ECG gated. Okay,
Okay.
this thoracic
Okay.
aorta is not performed at ECG gated, so that you
Okay.
can see some motion blur at the aortic root.
Okay. Okay.
If there
Okay.
is an aortic root injury, you cannot rule it out in this motion blur.
Okay. Okay.
Okay, so what we usually order them in case of acute aortic syndrome is do a non-contrast of the whole aorta. Number one. Number two, do an ECG gated thoracic aorta, and you
Okay.
don't need an ECG gated abdominal aorta. So we will see a non-ECG gated abdominal aorta scan. So this is
Okay.
the protocol for acute aortic syndrome with the with the mediastinal winding and things like that. Okay.
Okay. Okay.
Okay. Good. So this is a 3D reconstructed image as well, and you can see this kind of a punched out kind of a lesion and tear at the isthmus.
Okay.
So if we treat this injury and they ask for follow-up, what should be your follow-up? What imaging modality you will select for the follow-up of this case?
Um, for the for the follow-up, I think we can go for the MR, because that would be it would not be an acute indication. So I think it could be planned on the MR, angio could be done for that.
Okay, why Emma?
To reduce the radiation dose, I
Okay. Yes, good. And also the patient seemed to be young as well, so I think so it will be good to reduce.
thank you.
Okay, so this is your second case. Can you scroll?
Yes, yes, I can scroll. Okay, so I'm provided with the CCT chest arterial phase. I'm going to scroll from bottom to the top, uh, or I think top to the bottom will be better. Uh, okay, in this, I can appreciate that the contrast is normally opacifying the arch of aorta, and the um, main the right brachiocephalic and the left common carotid and the subclavian artery are originating normally from the aortic arch. As I'm going down, I can see that there is soft tissue thickening that is noted along the arch of the aorta. Now I'm going uh, I'm scrolling down along the ascending aorta, in which I can see that there is the thickening along the ascending aorta is increasing, and there is also marked surrounding stranding. And then I can appreciate that and, there is a tear or a thinned out. Okay, so there's a defect that is noted along the intimal lining of the aorta with the pooling of the contrast laterally within the wall, likely suggestive of an. I think this is a penetrating ulcer, and as I'm going down. This is not continuing. It is just at a short segment level, and the atrioventricular junction. It appears to be normal. It is not involving the root of the aorta. Now I can I think my it is the scrolling is going up and down. Sorry. Okay. Um, Now coming back. So the aortic root is fine, and basically the proximal portion of the ascending aorta is involved, and I can see that there is an penetrating ulcer that is noted along the proximal aspect of the ascending aorta, and there is also some soft tissue density area that could be a contained a rupture or hematoma formation, and I would like to review it on the pre-contrast images as well to see if there's any surrounding hematoma, and I would urgently pick up the phone and convey my findings to the referring physician, as this is an emergency, and the vascular surgeon needs to deal with it urgently. Uh,
Okay, good. So, yes, this is a penetrating atherosclerotic ulcer. Can you leave the mouse, please?
yes, sir.
Okay, can you stop controlling the screen?
Okay.
Okay, good. So this is a case of penetrating atherosclerotic ulcer. You can see there is a defect, the intima, and you can see this, then the tubular neck, and then this contrast outpouching within the wall of the ascending aorta. So, and also you need to classify it as it is in ascending aorta, you classified it as Stanford type A,
Okay. Okay.
because all the aortic, acute aortic, can you please mute yourself, please?
Sorry.
All the acute aortic syndromes can be classified as Stanford type A or Stanford type B. As it is involving ascending aorta, it should be classified as Stanford type A, a penetrating atherosclerotic ulcer involving the ascending aorta. Okay, and you're right, it is not reaching the aortic root. The next question can be, what are the three components of the aortic root? Can number one, can you tell me about the three components of the aortic root?
Yes, sir. Sir, I'll have to review. I think there's the aortic annulus, and then I think we go through at the level of the coronaries where the aortic sinus is, and I think atrioventricular junction. If I'm not, I think I'll
Okay.
have to review.
Okay, good. Good. So sinotubular junction, which is at the junction of the sinus of Valsalva and tubular portion of the ascending aorta. Then there is sinus of Valsalva, and then at the end there is the aortic annulus, as you have said, which will be the inferior most portion. Ideally, axial images should be made, the three-dimensional axial images in which we can review that. Okay. So one thing that you have missed in this case is the severe narrowing, extensive narrowing of the pulmonary artery, which is alarming. Okay, you should mention that as well. You can see this is the uh, right ventricle. Okay, and then this is the right ventricular outflow tract, and then there is the pulmonary artery, which is main pulmonary artery, severely narrowed here by this sclerotic penetrating ulcer. That's why surgery is really important in this case. Okay. So otherwise, your findings were really good. Uh, I will show you one X-ray, and then we'll move towards the next candidate. So it is an X-ray of the 17-year-old male patient. Candidate number one, can you describe the X-ray?
Yeah, yes, sir. So I'm provided with the radiograph chest frontal projection of a mature skeleton, in which I can, in the first look, I can appreciate that there are stenotomy sutures and seen within the midline. Other than that, the cardiac size is normal. I uh, I can appreciate that bilaterally the hyla appear to be slightly prominent, and the upper lobe vessels are also slightly prominent as compared to the lower lobe. However, I cannot appreciate any definite blunting of the bilateral CP angles, as I'm in my routine practice. I would also like to zoom the image to further look at the apices and also to see at the ribs. I cannot appreciate the aortic knuckle properly, and when I'm going through the other than
Okay.
that, I
Yeah, and you said you cannot appreciate the aortic knuckle properly. Can you see my mouse?
yes, sir, I can see your mouse.
Okay, so what do you think about this
I think it's
outcome?
making it is a figure. It is making a figure of three signs. I actually, if the image could have been zoomed properly, I wanted to appreciate the ribs for the notching.
There's no rib notching, I think, at the moment.
Okay, okay. So it is likely a case of a coquetation of aorta, and as it is making a figure of three sign, and I would like to further go ahead with MR angiogram as the patient is young to rule out the site of the coquetation, and if there's any other vascular anomaly associated with it, and to see if there's any, as there's no rib notching, but still I would like to rule out the collateral formation and.
Okay, so usually to look at the vascular anatomy, best is a CT scan
Okay.
for the planning as well. So initially we do a CT scan in all of these cases. Then follow-up imaging can be done by a MR angiogram
Okay.
in young
Okay.
patients. Okay, so
Okay.
in these cases, usually we will do an initial or a baseline CT angiography, and we will assess it on that, and then we will if needed for follow-ups, we will do MR angiographies. So what will be the benefit of a MR angiography from CT scan apart from a dose? What else you can detect in MR angiography?
Um, sir, I'm not sure on that. I said it because the patient was young to reduce the radiation dose. I wanted to
Okay.
go ahead with the MR angio.
Okay. So apart from the radiation dose advantage, we can also do flows through the of that area. You can we also get peak velocities through that area. We get mean pressure gradient through that area. which are some flow kinetics that we get to know from the MR angiography, which are not possible through CT angiography usually. Okay, so this is another advantage apart from radiation dose in these kind of cases. Candidate number 2, are you with us?
Assalamualaikum, sir. Yes,
Walaikum
sir.
salam. Walaikum salam. Thank you very much, candidate number 1. You have done really well. Well done. I really
Thank you,
like
sir.
your approach to cases, and I am happy that you have followed the things that we have discussed initially in our session. So, candidate number 2, um, can you review that CT scan? Can you ask
Okay.
for remote control, or do you want me to scroll?
Yes, sir. I'm requesting it.
Okay, scroll.
Yes, sir. I have got the control, but the images, I can't see the image actually.
You cannot see the image, or you cannot scroll the
No,
image.
sir. Image is small. I think some problem on my side.
Okay, it's okay. Just can you
Uh,
stop the screen control? I will scroll it for you.
yes, sir. Sir, now I can see the image.
Okay, so do you want to scroll now?
Yes, sir.
Okay, good.
These are the CT scan images. Contrast enhanced taken in the arterial face of a 17 years old male patient. I'm scrolling. I will scroll from top to bottom. Mm, so just a moment. I want to start it from the beginning. Yes. Okay. Now we'll start from top to bottom, and I can see there is a normal opacification of bilateral common carotid arteries, and there is a normal brachiocephalic artery. Right on the left side, I can see that yes, on the left side, I can see that left internal jugular vein. So just a moment, it's scrolling. Yes, I can see that aorta is SVC is normally seen on the right side. However, aorta is normally seen on the left side. It's normal. Now, as I'm scrolling down, I can see normal ascending aorta as well as the descending aorta. Pulmonary arteries, they appear normal to me. Uh, Left ventricle is normal. Opacified descending aorta is also normal. I'm unable to see any gross pathology on initial examination. I want to review it again. Uh, and now I can see that, yes, I can see that there is abrupt change in caliber of descending aorta in the distal to the origin of the left subclavian artery. And I want to confirm this on the coronal images because I'm suspicious about the coarctation of aorta. And although I don't appreciate any significant collaterals along the chest wall, along the paraspinal muscles, or along the intercostal spaces, but there could be two possibilities, whether it could be the coarctation of aorta or the interrupted aortic arch. Although appears normal. But next, I would like to confirm my findings on the coronal images, if available, or the sagittal images if available.
Uh, okay. Can you stop scrolling?
Yes.
Can you scroll now?
Mhm. These are the coronal images of the same patient. Sir, I'm unable to move it. Just wait a moment, please. So can you scroll it for me, please?
Okay. Can you stop controlling my
Yes.
screen?
Okay.
Yes, so here you can.
Yes. Yes, on the yes. Again, on the coronal images, again, I can appreciate the similar finding of the narrowing of abrupt narrowing in the caliber of aorta distal to the origin of subclavian artery with the post-stenotic dilatation, and these findings are in favor of coarctation of aorta. Next, I would like to convey my findings to the referring physician and would recommend a correlation with a difference in the blood pressure in the upper and the lower limbs, um, because these patients usually have the difference in the blood pressure. And next, cardiovascular, I will also refer the patient to the cardiovascular team for the management, for IR team for the management accordingly, whether angioplasty or stenting, whatever is needed in this case.
You think IR will be involved? Cardiovascular IR?
Yes, I think IR can help it.
You think or you know?
So, I I'm not sure, but I think IR can help it.
I think this is a young patient, so I think rather than stenting, because in young patient, if you insert a stent, it will have a very long-term complications. So
Okay.
in very young patients, either um, we usually go for surgical repairs, or if it is an IR, we can do an angioplasty. But in this case, usually I think a surgical repair are usually done. Okay, because
Okay.
these are young patients. So if you will insert a stent in a young patient for a long-term disease, it is prone to complications.
Mm-hmm.
Okay.
Okay. Okay.
So your next case, right-sided back pain in a patient with history of renal calculus, 60-year-old male patient.
Okay, sir. Mhm. Yes.
These are the images.
Okay. So CT scan abdomen of a 60 years old male patient taken in the post-contrast enhanced phase who has having back pain. In these images, what I can appreciate that striking abnormality is seen in the region in the abdominal aorta. So please stop it. Can you stop it here, please? Okay. I can appreciate there is an aneurysmal dilatation of abdominal aorta just distal to the origin of the renal arteries, and this aneurysmal dilatation is arising from posterior to the aorta, and it is secular in shape within and extending towards the right paravertebral location. It I can see that there is multiple ear loculi are seen in this aneurysmal dilatation, along with significant soft tissue stranding, and I can also see that it is wrapping vertebral body as well. However, in the given image, I don't there is moreover the outline of the aorta and this aneurysm is irregular with the stranding. However, in the visualized images, I can appreciate that the renal bilateral kidneys they appear normal. No evidence of any infarct is seen. So next, please scroll. Yes, I can see that this aneurysmal dilatation is extending up to the level of the bifurcation, and the right paravertebral collection, which I was talking initially, is actually I think this is um, a contained hematoma, contained extravasation or perforation of aortic aneurysm with significant stranding. So this is likely a case of secular aneurysm with the contained perforation. Um, I just want to look in the vertebral bodies to look for any
What
and
is
any.
the what are the types of aneurysm? Why are you calling it a secular aneurysm?
So there are two types of aneurysm: fusiform and the secular aneurysm. Fusiform aneurysms are usually atherosclerotic. Moreover, I can see multiple soft tissue density and the calcified plaques are also noted in the aorta. And the fusiform aneurysm is usually atherosclerotic. And considering the appearance and associated gas and the inflammatory stranding, I'm suspecting it is likely mycotic aneurysms, and mycotics are usually secular.
So you're calling it secular
Uh,
because you're thinking it is a mycotic aneurysm.
Mycotic aneurysm. Yes. And moreover, the rest of the aorta, it shows it is not ectatic. Usually in the fusiform aneurysms, the rest of the aorta, it's ectatic and dilated. However, the rest of the aorta, although it shows atherosclerotic changes, but its caliber is normal.
Okay. So what is your diagnosis? What would you do next?
So this is a case of mycotic aneurysm. Next, I would urgently convey my findings to the cardiovascular team for urgent treatment. These cases are usually treated with antibiotics and the debridement. So I would urgently involve a cardiovascular team for this treatment.
Cardiovascular surgical team or medical?
Surgical team.
And what do you think is this? This is
Sir, I think this is mycotic aneurysm with bleed, contained hematoma, contained rupture.
okay. So you think this is an active bleed,
Yes.
or is it an hematoma?
No, sir, it's active bleed,
It's active bleed.
contained rupture. Rupture, but it is not.
How do you know it is contained?
So because it is walled off by this collection.
Where is the collection? Which
So this
collection?
on the right vertebral location.
Is this
Yes,
collection or bleed?
yes.
Collection
So this
means
is, I
infective.
mean, then, sir, I'm talking about the soft tissue stranding and the air loculi, which is encasing this bleed.
So this is a collection you're saying.
Yes. Uh, sir, I want, yes, because I think it's an inflammatory process which is causing aneurysm and it's bleed, which is encased by this inflammatory process.
Okay. Okay. So what is usually done in these cases, as previously discussed as well, usually you will protocol these kind of a cases, like it needs to be supervised. If I see this kind of finding on a CT scan, I will do a delayed phase. Okay. I will see whether it increases or not.
Mm-hmm.
Okay. If it is
Mm-hmm.
an active bleed, it should increase or
Okay,
it
sir.
should change morphology. Okay. Please make yourself silent, mute yourself.
Yes, sir, please.
So in these kind of a cases, I will do a follow-up or delayed phase images. If it increases in size or changes morphology, so it means it is an activity. Please don't using my mouse.
Actually, I'm unable to find the
Okay,
uh,
wait. Just
mute option. That's why. Okay.
what have you done? Okay. So I think you need to, those of you who come for Vivas, they need to practice the settings of the
Actually, my laptop
Viva.
is stuck, so some problem
Uh,
is.
I can understand that. So please mute yourself now, or let me mute you. You don't do anything, okay? So those of candidates who have who are for Viva, they should please sort these issues beforehand, before your Viva, not at the time of Viva. If there is any issues with your laptops or things like that, you should sort these issues before your Viva. Um, remote control, stop remote control. Okay, now it's good. So in these cases, I was referring that we will do a delayed phase scan. Okay, and I will see if it increases in size or there is change in morphology. It means there is an active bleed. So the treatment will be different. Okay, but here they have done a delayed phase. They did a delayed phase. There was no change in morphology. There was no increase in that. It was persistently there. So it was a pseudoaneurysm. Okay. And regarding collection, there is a collection, but in the left psoas muscle. If you see, there is different, it is slightly hypodense. If you compare it to this, the medial portion is slightly more hypodense, and there is some air locules. So there is a collection, but in the left psoas muscle. Okay, there are multiple air locules, but I do not see any hypodense component here. Okay, so there is psoas abscess as well, but psoas abscess is in the left side. Right side, this could be an infective cavity in which there is a pseudoaneurysm formation, but this is now a pseudoaneurysm. It should be surgically removed, or surgically it should be resected, or surgical treatment should be done in this case. Okay, and yes, it is infected. It is a mycotic aneurysm. Uh, so. So well explained, but you should know about the different. If you would have scrolled down, you can see the airflow level here as well, which is indicating there is sauce abscess on the left side. And this could also be infected. Yes, you are right, but there is a pseudoaneurysm in this portion. And here you can see proper abscess formation here. Okay. Um, so good candidate number two. We have shown you two cases or one case. Candidate number two, can you unmute yourself?
So two cases. One coagutation and second one this.
So, candidate number two, so acute chest and abdominal pain, and this is the CT scan. Can you please describe the findings? I will scroll it for you.
Okay, sir. So CT scan chest taken in the arterial phase of an adult male patient. In these images, I can see the EGD is seen in trachea. I can appreciate that there is a curvilinear flap is noted in the ascending aorta. I want to see a root of aorta. So can you scroll it down, please? Yes, I can see that this thin flap is seen rising from the root of the aorta. However, it is not involving the sinuses, coronary sinuses. They are intact, and it seems to be extending into the arch of ascending aorta, then arch of aorta, and then descending aorta up till the level of suprarenal before the origin of. No, I can see that it is extending inferiorly caudally up till the level of the bifurcation and even into the iliac vessels as well. So this is likely due to the this is likely a case of aortic dissection. Next, I would like to see the origin of the main vessels, whether they are arising from true lumen or the false lumen. So can you scroll it up till the level of neck? Yes. Now I can see that think the right brachiocephalic artery is arising from the true lumen. However, the left common carotid and the left subclavian, they are arising from false lumen.
No.
Yes.
Okay. Can you comment on the renal perfusion, please?
Yes, at the level of the bilateral kidneys, I can see that the left kidney is not showing any opacification except for the faint cortical opacification at some places. However, focal defects, perfusion defects are noted in the right kidney at the lower pole. So this is likely due to the involvement of renal arteries. Left kidney is completely lost. However, the right kidney shows a lower lobe infarct. I would urgently convey my finding. This case falls at Stanford type B. I would urgently involve cardiovascular surgeon team for its urgent treatment.
Okay. So this is a Stanford type A because ascending aorta is involved. So if ascending
Sorry.
aorta is involved, A for ascending aorta, it will be Stanford
Yes.
type A. Okay. Stanford type B is medical management. Okay. So this is Stanford type A in which surgical management is required. Okay. Because it is involving the ascending aorta and can there is a dilatation of the aortic root as well and can go into the coronary arteries. Okay. So for this surgical management is required. Secondly, you can see hypoperfusion of the left kidney. Left kidney, almost all of the perfusion is lost in the left kidney, and you can see some perfusion defects in the right kidney as well. So this is a case of severe renal hypoperfusion, and it needs to be immediately informed to the surgical team so that they can revascularize the kidneys if possible. Otherwise, if lost, so there will be a patient might lose both the kidneys, which will be dangerous. Patient will be on the dialysis. So this is extremely dangerous and very important finding. Other finding which is also important is, if you can see, this is the true lumen, this is the false lumen. You can see severe narrowing of the true lumen as well, which is also alarming. Usually it is true lumen is small in size, but not so severe narrowing, which is sometimes neglected. But this is alarming as well. Okay, so this should be informed to the physician as well. And I think the upper ones are all arising from the supraortic vessels arising from the true lumen, not false lumen. So these are the some of the emergency findings, and these should be communicated to the surgical team. Okay, well done, candidate number 2. You did well. Just to recap the findings, which are really important. In the initial section we discussed, you need to look at the flow of the vessels. Number one. Number two, there are certain places which you need to focus, such as one here, where you can see the right upper low pulmonary vein draining into the SVC. Number one. Number two, you need to focus on the lateral aspect of the aortic arch. Number three, you need to focus at the aortopulmonary window. And number four, we discussed you need to focus at the level of aortic root. And number five, you need to focus at the level of descending thoracic aorta near the diaphragm, where you can see some systemic veins going into the systemic circulation. So these are the 5 points where you can find vascular anomalies in the thoracic aorta. So these are the points which need to be focused. Now coming towards the candidate number 3. Candidate number 3, are you online with us? Candidate number 3. Do we have a candidate number 3? We don't have a candidate number 3. Let's go to the question and answer section. Yes, sir, allow
So
me
I
to.
think candidate number 3 is available, but his or she is not co-host. That's why unable to unmute.
Okay, let me go. Candidate 3, can you unmute yourself? Candidate 2, please mute yourself.
Hello, sir. Assalamu alaikum.
Walaikum salam. Can you see the screen, candidate number 3?
Yes, sir, I can see the screen.
Okay, your voice quality is very low. I want you to increase or be close to the mic, or increase the sound quality while I answer the questions. How to differentiate between contained hematoma and pseudoaneurysm? I've already mentioned contained hematoma. It will be hyperdense. Pseudoaneurysm, usually it is vascular thing. It will be contrast opacified. It will have a narrow neck and then a kind of a bulge. It will have a communication with the vascular tree. Contained hematoma may not have this kind of a communication, active communication. Okay, how to share between aneurysm and pseudoaneurysm? Okay, so pseudoaneurysm, usually they are iatrogenic after a surgery, or they are associated with aquatic aneurysm, infective aneurysm. The differentiation is similar. Pseudoaneurysm will have a tubular neck and then a dilated portion, while aneurysm will be dilatation. Aneurysm can be fusiform secular. It can involve both the walls, or it can involve a single wall. So it will be and this could be the shape of the aneurysm. Sodium aneurysm, as previously said, need to have a tubular connection, and they can be either post-surgical or infective case of myocardial aneurysms. Okay, can you kindly explain origin of the brachiocephalic left common carotid left subclavian of the last case? Okay, I will show it to you. How to differentiate between the true and false lumen. Usually true lumen is the smaller lumen. Okay, false lumen is the larger lumen. And if I can show you. So this is the true lumen, which is anteriorly. This is the false lumen, which is posteriorly. False lumen is usually bigger. True lumen is usually smaller. True lumen, as it is continuous with the main blood flow, it will have more contrast enhancement. So the HU values of the true lumen will be more than the false lumen. Second point. Third point, in the false lumen, you will have some cobwebs. You can have some threads or cobweb or some thrombus as well, which can, some hypodensities will be there in the false lumen, but true lumen doesn't have these kind of hypodensities. Other thing, usually the false lumen curls around the true lumen. True lumen is smaller, and you can see if I go up, it will curl around the false lumen, curl around the true lumen. Okay, so going towards the branches, so this is the uh, right brachiocephalic artery, and you can see dissection going into that thin flap, going into that, and and then it divides into the right subclavian and right common carotid artery. And if I go down again, this is the left common carotid artery, which is arising from the true lumen, and this is the left subclavian artery, which is arising from the true lumen. At their origin, there is some dissection flaps are seen going in at their origin, present at their origin, but I think they're arising from the true lumen, not the false lumen. Okay, I hope it has cleared the questions. Can you please elaborate 5 points regarding aortic dissection? In cases of aortic dissection, the most important points are: see whether it is type A or type B. Number one. Number two is you need to look at the aortic dissection, whether there are any fenestrations in the aortic dissection or not. Sometimes we also are able to look at the entry point and exit points as well of the aortic dissection. The most clinically relevant things are renal perfusion is extremely important in this case. You need to look at the renal perfusion. You need to look at the arteries arising from the true and false lumen. This is important. The most important thing is there any coronary involvement or not? It will change the surgical approach as well. So these are the things that are on the top of my mind right now connected to the dissection. Okay, and the one thing that I have also mentioned, that if there is severe narrowing of the true lumen by the false lumen, this is also important, which is usually missed and is usually discussed in our aortic MDTs. This sometimes warrants a surgical approach to correct that. Okay. So and you need to look at the visceral vessels as well. And sometimes if there is a dissection in the visceral vessels such as SMA, celiac axis, or IMA, it can lead to bowel ischemia and things like that. So this is one point which is also really important. Okay. I hope it is clear. Now let's candidate 3. Is your mic working now?
Yes, sir. Hello, I'm here.
Okay, good. Now it's working. Candidate 5, we don't have candidate 5, but
Sit.
why do we need to see delayed image in phosphotonism? If it is the first scan, I would like to have a delayed image there to see whether there is extra contrast, extra vibration, or it is just a contained extravasation in the form of the pseudoaneurysm. Okay.
Sir, can you hear me now?
Yes, I can hear you. So, a 60-year-old male patient with acute chest pain. We have done a CT scan, after diagnosis. Can you look
So,
at the image?
60 years male patient.
Yes. Female patient, okay? Female patient, sorry, 60-year-old female patient.
This is CT chest, plain film, plain of a 60 years patient, in which I can see that there is a soft tissue density surrounding descending aorta. There is left-sided pleural effusion. The wall of the aorta appears a bit irregular, just at the ventricular level. Mm, the rest of the lung fields appear normal. So, is there contrast in? There is a crescentric hyperdense. There is a crescentric hyperdense area seen just adjacent to the aorta, and the wall on the lateral side appears irregular. There appears to be a break in it interiorly. So I think this is some leaking. This is some thrombosed wall with some leaking, and I would like to see the contrast study if available. In the contrast CT mediastinal window, I can see that there is aortic wall is irregular. There is an active extravasation anteriorly and laterally surrounding it. There is multiple irregularities along the wall, which is suggestive of multiple penetrating ulcers. The soft tissue density is going down. I would like to see its lower extent if available.
So, what is your diagnosis?
It is
And what will
penetrating
be
aortic ulcer with active bleed. These findings are should be urgently communicated to the referring physician and to the interventional radiology unit on call. And this thing should be urgently treated because the patient is at a risk of catastrophic bleed because there is activation going on.
Stanford?
Sorry, sir.
So, what will be the Stanford classification?
Stanford classification will be. So I would like to see the arch of the aorta.
It's just,
Arch of the aorta. So can you please go a bit further upwards?
no, no, ours is spared.
Okay, I think the aortic root is dilated with the hypodense thin line within it, and it looks like Stanford. Sir, I wanted to see the arch, the room, and the continuity of the descending aorta with it.
Okay. I don't have the arch, then what should?
Okay, it looks like a Stanford A, which needs to be urgently repaired
Okay.
surgically after the
And
patient is stable, obviously.
it is Stanford type B. I said ours is spared. So,
Oh, sorry.
so listen to what examiner says very carefully. Okay, he's just showing you focused images of descending thoracic aorta, and he's telling you the arch is paired. So in FRCR 2B exam, the examiner won't trick you. He will try to guide you. In FCPS exam, I can understand it is a completely different situation. Okay, the
Hmm.
thin linear opacity that you see here in the aortic root or ascending aorta, these are all motion related because this is not an
Okay,
ECG gated send. Ideally, it should be done an ECG gated thoracic aorta. Okay, so
okay.
and Second thing, this is not atherosclerotic, penetrating atherosclerotic ulcer. I have shown you a case of that. You can look at that and differentiate. This is case of intramural hematoma. Okay. So I
Hmm.
really liked your wording. So if you can see that there is a crescenteric shape hyperdensity. So it is very when you use that word crescenteric, I thought that you have picked up the diagnosis. So you see here the crescenteric shaped hypodensity.
Yes.
Usually in the case of intramural hematoma, there is asymmetric crescenteric shaped hyperdensity of the aortic valve. Okay,
Hmm. Okay.
so which is diagnostic for intramural hematoma. Okay. And
Okay.
intramural hematoma as well, you can see some kind of a active leakage, which is common in intramural. So if you see some kind of a active leakage here, this is common in intramural hematoma. We see that you follow it up as well. Yeah.
Okay, sir.
So it was a case of intramural hematoma. So try to view all the acute aortic syndromes. You should know what are the different types of acute aortic syndromes and how they look on imaging. Okay.
Okay, sir.
So this is your next case, chronic shortness of breath, recent hoarseness of voice. Okay, so
This is a CT chest contrast enhanced of a skeletally mature individual in which I can see that there's massive dilatation of aortic root and of pulmonary artery and the main trunk as well as its both branches. So I would like to see the right ventricle, which appears normal. The left ventricle is a bit distended and with a slight bulge, but there is no pericardial abnormal thickening or any pericardial fluid. Sir, can I see the second and third order branches of the pulmonary vessels are also dilated? Yeah, these ones going till the basis, and I can see that there is normal valve. Yeah, this can be seen in the but there's massive dilatation of the main pulmonary trunk and both of its branches. Mm, sir, can I see the coronal to see any add-on findings? Renal hypertension.
okay. So what is your diagnosis?
Um, sir, my diagnosis is pulmonary arterial hypertension.
What is the cause?
Sir, cause I was trying to figure out, I cannot reach it, but I think this is a case of pulmonary arterial hypertension.
Okay.
And I would like to communicate my
What do
findings
you
to
think
the
what should
doctor.
be the cause?
Sorry, sir.
What do you think what can be the cause of that?
Sir, cause can be idiopathic or it could be some ASD,
Okay.
VSD. Sir, is there, sir, I want to see the atria once more.
Yeah. So you can see, I think there is some filling defect here. So there was an ASD, and you can see extensively enlarged right-sided cardiac chamber. Right atrium and right ventricle are extensively dilated, which also shows that there is some shunting. Okay, if there is some shunting, then the right-sided cardiac chambers are dilated. Okay,
Okay,
and there is a pulmonary arterial hypertension, rightly mentioned. But as the pulmonary arteries are dilated, is also causing some other effects as well. But these are the most important things that you mentioned. Okay, let's go towards the next case. I think this is probably the last case of just the main incidental finding. So yes, do you want me to scroll it?
Yes, sir.
Okay.
This is CT chest contrast and hence mediastinal window of a skeletally mature individual, and I can see that there is a filling defect in the superior vena cava, which is uh, located towards its lateral margin. The brachiocephalic vein appears normal. The filling defect is extending up till jugular veins. I want to see its lower extent as well, whether it is continuing into the right atrium or not.
What
Um,
is the phase of the scan?
Phase of the
Phase of the scan. Phase.
phase. This is arterial phase.
So would you comment on?
No, 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 no. I don't think it is superior vena cava. It is. Mm,
So
this is
you're pointing out to this thing.
yes, yes. This thing exactly.
Would you comment on SVC filling defects in arterial phase CT scan?
Mm, no, sorry. So I
If
want to. Yes.
you see filling of the right atrium, it is less. There is more filling of the left atrium, and these
Yes, exactly.
filling defects are usually phase related. They are not real. Okay,
Okay.
not
Okay.
the uh, venous phase. So tune your eyes according to the phase, because in UK we do arterial phase of CT chest rather than venous phase most of the times. So your eye should be tuned according to that. Secondly, initially in the initial lecture, I discussed about 6 points, 5 points, 5 points which need to be reviewed for the vascular anomalies. Can you re-enumerate them?
Sorry, sir. I don't remember.
Okay, so first point was um, at the junction of the at the site of interposition of the SVC and the right upper lobe pulmonary vein. Okay, so
Mm,
this was the first point. Okay, that the SVC and IVC should drain into the right atrium, while the pulmonary veins, all of them should drain into the left atrium. You can see them
mm,
draining into
okay.
the left atrium. Okay.
Okay.
The second point was to look at lateral to the aortic arch. There should be no structure, vascular structure lateral to the aortic arch. If there is
Okay.
a vascular structure lateral to the aortic arch, then you need to scroll up and identify where it is going. So here you can see uh, through the left, this is the left brachiocephalic vein. There is a vein which is draining into the left brachiocephalic vein, and it is coming, you can see it lateral to the aortic arch. So that's why this point is really important. Okay, you can see
Okay.
it, and it is the left upper lobar pulmonary vein, which is
Okay.
going to the left brachiocephalic vein. So it is a partial anomalous pulmonary venous return. It is a shunt. Okay, so this was the second point where you need to look at it. So no vascular structure
Mm,
should be lateral to the aortic arch. Third point was to look at the aortopulmonary window. Okay, the fourth
okay.
point was to look at the aortic root. Okay? And the fifth point was to look at anteriorly the descending aorta near the diaphragm. So these are the 5 points that you need to look at if you want to rule out any vascular anomalies. Okay, if
Okay.
you look closely at these 5 points and you do not find anything suspicious, so then you can be confident. Okay, so
Okay.
you need to keep these things in mind. And anomalous, I was shown a case of left-sided SVC in my exam, so you can see these kind of findings in your exam
So,
as well.
sir, what's the diagnosis in this case?
So partial anomalous pulmonary venous return. It is a shunt. Okay, so there is shunting of blood from one side to the other side. So you can see this left upper lobar pulmonary vein is draining into the brachiocephalic vein,
Hmm.
then SVC, then into right atrium. It should drain into
Hmm.
the left atrium, not right atrium. So there is a
Hmm.
shunt, and these anomalous pulmonary venous return, they are associated with ASD as well, particularly the right-sided one. So the right-sided one are associated with sinus venosus ASD. So these things are
Okay, sir.
really important, okay, for the clinical diagnosis. Okay, so
Okay, sir.
you can see three structures here, and you can see brachiocephalic vein, or as we see here. You should not see a fourth structure here at this slice, okay,
Okay,
or
sir.
anything lateral to the vascular structure, lateral to the aortic arch. Okay, this is always abnormal. You need to look at this area. And so these are the specific corners of the heart which you need to focus if you want to rule out any vascular anomalies. Okay,
Okay,
in
sir.
practice. Thank you very much. Well done, candidate number 3. Do you have any feedback? Anything that you want to
Thank you,
say?
sir. Thank you.
Okay, thank you. Thank you very much. So I have, I think I have shared answers of all the questions. I will share the link for the feedback here as well. I think someone previously asked me. Hope it is shared, everyone. Here is the feedback link. It is really important that you fill this feedback link. So it helps us improve our session. So any positive or negative feedback you can write in this, and it will help us in improving the sessions. Please write your comments in that. I personally read these comments, and will try to uh, do things differently so that I can improve my session. So I will share the screen again to tell you about these 5 points that I focused on. So these are the five. This is the 5 corner approach. Okay, 5 corners to look for the vascular anomalies and vascular abnormalities related to cardiac. This is taken from an article shared in the radiology assistant. So you can go to the radiology assistant and you can find all these things there. So there are two approaches that have been shared. One is go with the flow method to look at the normal flow. Anything abnormal, you need to detect that. And there are 5 corners or 5 places, 5 key areas where you need to look uh, to see the anomalies. So I have given the link as well of the radiology assistant. So you can see that 5 key areas are right superior pulmonary vein and SVC point intersection lateral to the aortic arch, descending aorta at the diaphragm, aortic root, aortopulmonary window. Okay. So if you look at these 5 areas, key areas, you will be able to differentiate most of the anomalies, okay, on a routine scan. Thank you. Last case of the candidate 3, last case of the candidate 3 was partial anomalous pulmonary venous return. Um, so this is the last case of the candidate 3. If you look at this case, you can see there is a vascular structure which is draining the left lung, okay, and it is going upward, and it is the vascular structure is draining into the left brachiocephalic vein. So it is a pulmonary vein which is draining into the left brachiocephalic vein, which is draining into the right atrium. Okay, all the pulmonary veins should ideally drain into the left atrium, but this left upper lobe pulmonary vein through the left brachiocephalic vein, it is draining into the right atrium. So it is called partial anomalous pulmonary venous return. It is an abnormal pulmonary venous return into the right atrium. Okay, it is kind of a shunting of blood. Okay, I hope this is simple. Are there any questions? Thank you very much, everyone, for attending this session. I think I have answered most of these questions. I will share the feedback link again. If you have any feedback, please write your comments, so it helps us improve our sessions, and I read my feedbacks myself. Thank you very much once again, everyone, for joining in, and thank you very much for all the candidates. You've done really well. And I hope and I wish you best of luck for your exams. Okay, so thanks very much. I will keep the feedback form link here for 4 to 5 minutes, then I will close the session. Okay, thank you very much. Bye.